very happy that a lot of you came for the last session of the Health Law Seminar Series at the end of term. So we don't have so many students, but I'm happy to see some of our students on this quite an important topic. We thought it was timely to have a discussion starting in Toronto on the issues of medical assistance in dying and mental health, and also in relation to that, and Dr. Harvey Schipper will say something more about that, the topic of dementia and euthanasia. These are two areas where there is quite some controversy and where there is at the same time pressure to expand the relevant Canadian legislation. So we had Council of Canadian Academies reports that discussed some of these issues, and that was the occasion basically to bring together a group of experts, some of whom or several of whom have been involved in the Council of Canadian Academies report. So Dr. Schipper will chair the session, will provide some introductory comments, and we go from there. If you need a copy of the biographies, we'll be very short about these. My secretary made copies of all the biographies, so I'll let them here on the corner. If you need them, you can make a sign to me. Dr. Schipper.
Thank you. Thank you very much. It's a pleasure to be here. I'm a professor of medicine and here in Toronto, and also an adjunct professor of law here, and I'm one of 3 people on today's panel who were part of the Council of Canadian Academies expert, 4 people. I can't even count anymore. 4 people on today's panel who were part of the Council of Canadian Academies expert panel, which just before Christmas tabled a just shy of 800-page overview of what the state-of-the-art of thinking about this topic was. For those few of you who may not be familiar with the context in which all this arose, the issue of some form of assisted dying has sat in Canadian society for a long time. In fact, it's sat in other societies around the world for hundreds of years, but the more contemporary exploration of that issue, of course, started with the Rodriguez case in the Supreme Court quite a number of years ago, where in a close 5-4 decision, her request for assisted dying was turned down. More recently, we had the Carter decision several years ago, where a new legal nuance, the notion of making this a charter case and the concept that if someone could not arrange to have their life ended in the presence of intolerable suffering by their own hand or by some other means, they would be forced to end their lives sooner than they would otherwise do so. And so, out of human rights and individual autonomy considerations, the court ruled that under very defined circumstances, as defined in legal terms, some form of assisted dying would be provided. And that, of course, set off a whole range of activities, including deep discussions on a whole range of topics that keep growing and growing out of the very simple apparent notion that someone should be able to have their life medically ended under defined circumstances. You may recall that led, after a little bit of requested delay, to the passage of C-14, which was the federal act which created an exemption, carved out an exemption in the criminal law for the ending of someone's life under very defined circumstances. And the range of those circumstances, of course, is being tested in the courts and in practice around this country as we speak. One of the things that came out of that, C-14, was an explicit requirement that Parliament commission an expert group to look at the issues as broadly as they could, particularly in 3 areas which the current legislation does not allow, namely the concept of an advance directive, in the context of mental health, and for mature minors. And the Council of Canadian Academies convened a unified experience of 3 panels, each of about 12 or 13 experts of international stature to address these issues. One of the explicit mandates of the Council of Canadian Academies request was that we not issue recommendations. It was really to lay out the evidence so that the legislators at a later date, probably at the 5-year review of C14 and certainly into the next government, would then have materials with which they could belabor a decision about how C14 would be altered in one way or another. So all this is going on. We have, in fact, the reality of medical assistance in dying in Canada. And the last official count was about 3,700, I think, people had gone that route in Canada through the middle of last year, I think it was. And the discussions and considerations continue. And that's the purpose of today's conversation. And I'm surrounded by extraordinary people who've thought about this at great length. And I'm going to introduce them very briefly and then ask them to introduce themselves a bit to give you a bit of their context of how they became involved in this and what their perspective is. Then one of them, K.Sonu, who's professor of psychiatry here at the University of Toronto, will report briefly on the mental health report that came out of the Council of Canadian Academies. And my colleague Trudo Lemmens will comment on what came out of the Advanced Directives panel, of which he and I were members. And then you've had circulated to you capsule summaries of a number of cases from the Benelux countries. And we're not proposing to go through all of them, but as you'll see, we're going to open a discussion among the panelists. There are always rich discussions in this topic. My lawyer daughter calls assisted dying an immortal topic, and I think you'll see that, and we may refer to these cases along the way to elaborate the issues a little bit. There will be plenty of time for your input. All of us are going to welcome it. This is really seen as a conversation around this table. It will run to approximately 4 o'clock. And let me simply start by saying thank you all for finding time to come and join with us. So let me start going around the table. First, let me introduce our first panelist, who's Scott Kim, who's a psychiatrist at the National Institutes of Health in Washington, D.C. Scott, do you want to tell us a little bit how you got here?
Oh, so I'm a psychiatrist. I'm also a bioethicist. I have a PhD in philosophy as well. And this is the reason why I make frequent trips to Canada actually is because some years ago I looked at the issue of what do we know about euthanasia and assisted suicide, which is I use that term because that is a legal term in the Netherlands and Belgium, for people with psychiatric and other neuropsychiatric disorders. And I found out that you can actually study them because there are actually cases that are published by the official review committees. And I have done these analyses of reported cases and impediments in these 2 domains, mostly in psychiatric, but currently working on dementia cases. And my interest is in really looking at the patient level. Who are these patients? How do doctors evaluate these patients? And in applying the criteria, and how does the review and monitoring committee actually provide oversight? So that's the perspective as somebody who's really read a lot of these cases and has done studies. I hope to bring some perspective from that angle.
Next to my right is Marcia Sokolowski, who is a psychologist and PhD philosopher, who's a member of our joint Center for Bioethics.
Thank you. Hi, welcome everybody. Pleasure to be here. And my interest really stems out of very long-standing work with people with dementia and being very interested in what it means to have capacity, where the legal views, frameworks for capacity, perhaps is at odds with other forms of views of capacity, what it means to be an autonomous person, how autonomy and capacity often are conflated, and how it would make better sense to reapply some concepts to people with dementia to give them, I would say, more respect from a personhood point of view. I've become very interested in the application of advanced directives with the dementia population, and other ways of trying to circumvent the problem of the now person versus the then person, and how we can get out of that box, because I find that it doesn't really help us clinically or really speak to the whole notion of who people are. So I've become interested in the government looking now at the possibility, I know it's certainly not a done deal, but at least the possibility of allowing for advance requests for MAID. And I've been doing quite a bit of thinking about, are there specifics around the concepts and notions of MAID that are unique when we think about advanced directives with dementia.
And next is K.Sonu, who is Professor of Psychiatry here at the University of Toronto out in Mississauga.
Thanks, Harvey, and thank you, Trudo, for inviting me to this panel. I'm thrilled that there's such excitement in the faculty on this topic as it's evolving. My background is that I'm a psychiatrist, like Scott. I'm the chief of psychiatry of the Humber River Hospital in West End, Toronto. And I became involved in this as the Carter decision was unfolding, and subsequently as the government was trying to navigate its path through developing policy to in response to the Carter decision. And that was largely my capacity through the presidency of the Canadian Psychiatric Association, which ended up overlapping around the same time that all of these other issues were unfolding. So in that context, I mean, we'll talk a little bit about this later, but as you know, the Carter decision does mention psychological suffering, but it doesn't provide really any guidance, nor did it have any kind of review of how to deal with issues of mental illness. And the entire field, at least in Canada, about how assisted dying could exist and coexist with mental illness issues really wasn't explored. My involvement was in assisting the organization or National Association develop policies as best as possible for providing guidance to the dialogue and testifying at a number of the varied committees and hearings that were going on around that time. I also chaired our Canadian Psychiatric Association task force on assisted dying, which was a time-limited task force, wrapped up around the same time as the CCA reports came out, actually. And along with Scott, sat on the CCA expert panel on mental disorders. And I am continuing as the physician chair of our hospital assisted dying committee, both the steering committee and the IRG. And I think Rosie is here as well as this one. So, thank you.
Thank you, K.Sonu. And sitting to my left is Alison Thompson, who is an associate professor in the Leslie Dan School of Pharmacy and the Dalai Lama School of Public Health. And in fact, we first came together in the context of working on a paper looking at capacity.
It's a pleasure to be here today. I have been involved, as Harvey said, in a number of qualitative studies looking at suffering in the context of MAID. First was for the Law Commission of Ontario, looking at whether suffering, in particular intolerable suffering, what do clinicians think about what it might do to people's capacity to provide consent to anything at end of life, not just medical assistance in dying. And then my PhD student, who's sitting over there, Michelle DeRizio, has been engaged in a study that built off that one, with interviews with clinicians around the concept of existential suffering and its medicalization. And when we started looking at this, MAID had not yet been legalized or decriminalized in Canada. So we have a really interesting set of data that spans sort of pre and post decriminalization. So it's interesting to see how clinicians shifted in the way they talked about suffering in that context. And then I'm also engaged currently in a study that's comparing clinician assessments of suffering in different jurisdictions. So Quebec has different legislation around MAID, and so we're interviewing clinicians involved in the assessment of suffering in Quebec and in Ontario, and trying to come up with some ethics-related insights into how suffering is being assessed and whether there are ethical issues arising from that particular aspect of the request for MAID.
I'm going to skip all the way over to the end of my left, and Dr. Donna Stewart started out as a family physician. She's a psychiatrist, and she's been deeply involved on the ground in the issues of assessments of eligibility for MAID since it became a possibility in this country.
Thank you. So yes, thank you very much for inviting me today. Since MAID became legal in Canada, I've been very involved in a MAID implementation team at University Health Network. And you probably know that network involves Toronto General Hospital, Toronto Western, Princess Margaret, the Toronto Rehab Institute, and Michener. And since this has been legal, I've probably assessed well over 100 cases. And from that, I've gained a certain appreciation of the kind of person who's interested in MAID. And I know that there was a lot of concern initially that these would be vulnerable people. My impression is that these are highly effective, successful people who have in general been in control of their lives. They've often been professionals of various sorts, lots of doctors, nurses, lawyers, industrial leaders, and they now want to be in control of their death. And it's been an interesting dialogue. We're not seeing people that one would traditionally call vulnerable. I think out of over 100 cases, I've seen only 2 people I would term vulnerable. So it's an interesting time, and certainly there's some challenges in doing these assessments, and I look forward to discussing some of those as the panel proceeds. Thank you.
Thank you. Trudo, you've already been introduced and everybody knows you. I don't know if you want to say anything further.
So maybe simply for those people who don't know my involvement in this debate, so I'm originally from Belgium, so my mother tongue is Dutch. I've written on euthanasia, as it was certainly then called, some articles in the 1990s. And when the Carter case came out, I became particularly involved because I was already working on a chapter looking at some of the changes or some of the developments in the context of the Belgian euthanasia practice that I had been observing and that I felt would be interesting to discuss. When the Carter case came out, I felt that there was a need in Canada to look in more detail at some of the developments in Belgium and the Netherlands, which I followed closely, because there was often a portrayal of the situation as if things were very straightforward and well-going, and there was no real significant controversy in Belgium and the Netherlands. So I wrote from that perspective to kind of at least alert the Canadian public about some of this. I translated some op-ed pieces. I also personally had a different interpretation from, or shared with some others, a different interpretation of the Carter decision as being more narrow than has often been portrayed. So from a legal perspective and from a policy perspective, I came to this more from the angle of, well, we have to kind of look at what would happen if we embrace a more Belgian or a Dutch style model, and we have to learn from some of the things that are happening there.
Thank you. Before we plunge into this, because our topic is focused in particular on advanced directives and mental health issues and capacity, we've asked K.Sonu and Trudo to summarize respectively their experience, what they took out of this very intense, roughly 18-month exercise that the Council of Canadian Academies challenged us to. Sonu, do you want to talk a little about the mental health?
Sure, thanks. Glad to. And I do have some slides, so I'm going to whip through them quite quickly, but I'm going to take about 10 to 12 minutes to present a little bit of a framework on why I think the mental illness issues are particularly relevant, a lens to look through as we're considering potential expansion, because there are some issues that we looked at in the mental illness area that actually may have relevance even outside that for populations that expansion potentially could refer to. Very quickly, I'll just go over a bit of the background context, where we're at now, and then what we're looking at moving forward coming out of the CCA reports. In terms of the Carter decision, as was alluded to earlier, decision from 2015, spoke to psychological suffering being on par and equally valued as any other kind of suffering. What it didn't speak to was what exactly that meant. Did that mean suffering from mental illness specifically, or other things? So it didn't provide any guidance, nor were there any cases that were reviewed involving mental illness in the Carter decision. And there are many pieces that you can pull apart in terms of similarities and differences for mental illness versus physical illnesses and the other areas we're talking about. But I'm going to try to hone down on just about 3 different areas to get you to consider how some issues are potentially unique, or I shouldn't say unique, but different for different conditions. So Harvey alluded to the Section 7 infringements that the court found, and you know what those were. You know that they covered all 3 of these areas, life, liberty, and security. I can tell you that when I speak in front of clinical audiences, they are surprised that it covered life. They don't quite get that argument until it's explained to them. The idea that if somebody is on a path of decline, and they may get to a point where they can no longer take their own life, if they were to choose to take their life sooner than they otherwise would, or otherwise would want to, that's a period of foreshortened life. Therefore, we're infringing on their right to life. The reason I'm focusing on that one is, consider how that plays out for mental illness. Mental illnesses can do many things. They lead to terrible suffering. They can lead to changes in capacity, various other issues. They rarely lead to a loss of physical agency to act. So that's one distinction that hasn't yet been tested, how that plays out in terms of loss of agency to act on the infringement on life. Now you'll recall that while the process was going through and C-14 was being drafted and all of the consultations were being done, there was a period of time where, I guess on an individual case review basis, cases could still be heard. And there was one case during that time that was for sole criterion mental illness that received MAID. And that's the EF case from Alberta that went to the Court of Appeal there. That case involved a patient with conversion disorder, which essentially refers to a condition where someone has all sorts of physical symptoms and we can't find a physical explanation for it. So no kind of biological physical diagnosis was found. This was a lady who had terrible intractable spasms, needed to be lifted from bed, at times couldn't open her eyes to see, etc. Her family was supportive of her getting this, and she applied and was able to get MAID. So that's the only case in Canada that's received MAID for sole criterion mental illness. It also is a bit of a cautionary tale, I would suggest, because when you look at some of the things that unfolded from that case, I won't comment on all of them, but one thing clearly jumps out, that in the public documents, it mentions the psychiatrist who reviewed the case and opined on it, never actually spoke to the patient. That they assessed not just irremediability, but also capacity by chart review. Now, what that should point out is that in the absence of standards, we don't quite know what will happen, because there were no standards for how you determine whether someone should get MAID for sole criterion mental illness. So the caution there is, when standards don't exist for certain things, it becomes potentially a little bit of the Wild West, and we don't know what outcomes will actually occur. So moving forward to where we're at now, again, I won't go over this, you know this well, I'm sure, but these are the criteria that came from C-14 that subsequently were enacted in legislation. But I will point out a couple of things in terms of the definition of grievous and irremediable. So one thing, if you recall, I can't remember which of the Senate reports it was, but one of them, they actually commented on the fact that irremediability is well defined in medicine. And they cite work by the CMA, I think also by the CPSO. I'm going to challenge that for whether that's as well defined in mental illness, and spoiler alert, it's not. So some of the issues that are taken as assumptions in medicine do not necessarily hold true for mental illness. And the one I'll point out, which is probably the most relevant, is advanced state of irreversible decline in capability. But the other one that I've put in parentheses, the C criteria, that intolerable suffering can't be relieved under conditions considered acceptable. I'll come back to that a little bit later in the context of one of the CCA conclusions. You know that the preamble to C14, it laid out that there were the 3 conditions Harvey alluded to that required further study, and that subsequently led to the CCA panels, one of which was the mental illness panel. And I will go over what some of the highlights of that report were. But just to pose this question, why are we carving out mental illness? You know, we talk in mental health about the need to avoid stigma and discrimination all the time. Our patients have been discriminated against for as long as we know. And so the idea that they're treated differently potentially raises some concerns. But it also raises the question of what discrimination is. That is it treating people who are the same differently, or is it treating situations that may be different the same? And that's part of what I hope you think about as we come out of this. But just to point out that in terms of how mental illness is treated across the globe, it is treated differently, because there are only 4 jurisdictions where it's currently allowed for sole criteria mental illness reasons, the Benelux countries and Switzerland, as you see it. So just in a very quick nutshell, what are some of the things that may be different when mental illnesses are concerned? And I've put up here what are recognized as common cognitive, they're called distortions, but they're called distortions because they change how someone may think compared to when they are not under the influence of or suffering from symptoms of mental illness. So the classic one with depression is, I suck, the world sucks, and the future will suck. I'm bad, the world is bad, and the future is bad. And there's a loss of cognitive flexibility. People lose the ability to see things in a different way, and on top of that, tend to focus on the negative and discount the positive. And we've even found that biologically, many of these changes seem associated with changes we are now recognizing on functional scans in the brain, including the loss of ability in some cases to actually envision or see a future. So think about what that means for a second. That if part of the brain is shut down, you have these changes, and you also can't even, you know, it's as literal as if I can't see a tree and I'm walking in front of it. If part of the brain can't work to see a future, how does that change your decision making potentially? And the key thing here is not to suggest that everyone with these changes lacks competence. Usually they don't. Most patients with mental illness have formal capacity. That's actually what creates the challenge. Because the point is that you can retain formal capacity and still have significant impact on thought processes and decisions. So how do we deal with that in an ethical way and in a way that respects the person's autonomy? The second thing I'll point out, so that I would call the current state challenge. The future challenge, the future prediction challenge, is actually even bigger. So you remember that I meant to focus on the irremediability piece, especially in terms of irreversibility. So what does irremediability mean, or remediability mean? Does it mean remediability of symptoms of illness? Does it mean remediability of psychosocial factors, like loneliness, poverty, other things that we know are highly concurrent with mental illness and other conditions of suffering? Does it mean all of it? And what does irremediability mean? Because remediability, you know, as a clinician, I walk into a room and I think, how can I improve things in any of the different areas I'm looking at? Irremediability is quite different. It's a dichotomous distinction of saying, now this situation is irremediable. So how does that play out in mental illness? Well, there are 2 things that I'll point out here, that both the Canadian Psychiatric Association back in April 2016, as things were unfolding prior to C14, said, and keep in mind that most professional associations like to say what they know. They don't like to say what they don't know. what they said was there's no established standard of care in Canada, or as far as we know in the world, for defining the threshold when typical psychiatric conditions should be considered irremediable. And subsequent to that, I think this was about a year later, in October 2017, CAMH similarly said that at any point in time, it may appear that an individual is not responding to interventions, that their illness is currently irremediable. But it is not possible to determine with any certainty the course of this individual's illness. There's simply not enough evidence available to ascertain whether a particular individual has an irremediable mental illness. So how does that play out? One of our criteria is you need to have an irremediable condition. I don't have an answer for you, but these are things that the CCA started to look at. So what did we do? You know, as Harvey said, it was nearly a year and a half. It's 15-member expert panel from across the country and internationally, nearly a 200-page report, 40 pages of reference, 25 key findings emerged from it, and I'm not going to focus on those. Because right at the beginning, one of the things that was said is that in some situations, even after consideration of available data and panel discussion, agreement could not be achieved and significant differences of opinion remain, reflecting the complex and conflicted nature of the issues under study. So think about that for a second. A year and a half, you pull together people, you do intensive study, you still can't actually come up with key agreement on some key areas. One of the things which also is in there is the 5 areas of fundamental disagreement that were highlighted. And those are what I'm going to point out, because those are the tricky ones to resolve. And the other thing that I'll just point out prior to getting to that is that one of the things that emerged, not just from the mental illness piece, but in general, is that, and think back to the criteria C that I had in parenthesis, that suffering needs to be remediable under conditions that the person finds acceptable. That is unique to Canada. So when you look at the other countries, including the Benelux countries that otherwise have more liberal laws that allow it for wider reasons, it is not a purely subjective assessment based on whether the patient wants treatment or not. So the CCA conclusion was that no other country permits MAID for sole criteria mental conditions where one of the eligibility criteria is based on an individual's personal assessment of what conditions for relief of their intolerable suffering they consider acceptable. Because in those jurisdictions, there is some requirement that the person has demonstrated some attempts at treatment, and there's a clinical assessment that further treatment may be futile. If Canada were to expand MAID for sole mental illness conditions using this criteria, it could become the most permissive jurisdiction in the world with respect to how relief of suffering is evaluated. And then just to end on this, I won't read these, but these were the areas of significant disagreement that are highlighted. And if you look at the report, there's a bit of a narrative description of each of these to explain a little bit more. But one of the ones as mental illness piece that I'll point out, and I think Scott will probably speak to it at some point, is the distinguishing between MAID for mental illness versus suicide drugs. And that's a very tricky one, because you start to think about which populations are we now looking at, and there is some evidence that suggests it may be difficult to tease those populations apart. And I think with that, I will, actually the last thing I'll point out is that unlike any other medical condition, suicide or suicidality is actually a core symptom of some mental illnesses. So it's a symptom of cardiac illness or other things, for example. So, just stuff to think about, and I hope that you have some answers for us.
So I think you can see that what might have sounded like a relatively straightforward conversation gets more and more layered and more complex. And when we add to it now the notion also of an advanced directive, which was the other panel, you'll get another sense of the complexity of the issue. Trudo?
Okay, just a second.
While we're waiting just for the technical hookup, does anyone have a quick question for K.Sonu? We'll come back later, obviously. Ready to go?
Yeah.
Okay.
So, very briefly, I just want to highlight a key issue that was discussed with respect to the discussion that we're having today. So the Council of Canadian Academies subgroup on advance requests for MAID, and I have didn't only discuss issues of advance requests for dementia. So the mandate of the subcommittee was to look in general at what would happen if we, or what are the circumstances under which people may want to have medical assistance in dying on the basis of a prior expressed wish at a time when they are no longer have capacity. The consent requirements were particularly important also for the requirement that we have under the current Canadian law that we have a reflection period of 10 days between the day of a signing of a request for MAID and the provision of medical assistance in dying. So in other words, people have to be able to confirm that they still, after 10 days, normally want to have medical assistance in dying. There is an exemption though, so if for this 10-day period, for people whose death or whose loss of capacity to consent is imminent, so in that case, the procedure can actually happen more quickly, which shouldn't be forgotten. So in cases where there isn't a danger of an imminent loss of capacity, we already have this flexibility under the Canadian law. But there was certainly, also on the basis of controversies that are widely known in the Canadian context, cases where people felt that they were towards, on a path towards declining health and towards death finally, and that they wanted to know whether, if they expressed their desire to die now, could receive MAID at a point in the future when they no longer had capacity. The biggest controversy, I think, arose for sure in the context of dementia, simply because, and I'll mention the ethical conundrums in the context of dementia, because we have there a contrast between the current autonomy of people who often still are among us, have a certain sense of their environment, interact with their environment, but may have different interests and different experiences in the world than that they had when they were still capable of decision making. So this is, I think, the key issue in the context of advance request for dementia. Not the only issue, but one of the key issues in the context of dementia. There's also another issue which comes closer to the mental health context more generally, which is that often people with dementia may still have some level of capacity, and that there will be questions about do they still fully understand and appreciate the consequences of having MAID procedure at a time when they're declining and when other people have the impression that they may want to die. So those who have defended the industry, you saw on the panel certainly a clash between different visions about what should count more. So some people feel very strongly that if you are now full capacity and you see yourself on a declining path towards dementia, you should be able to say, I want to have in the future euthanasia when I no longer recognize my family members, or when I'm completely dependent on others, or when I can't clean myself anymore, when I don't have any meaningful cognitive interaction. So these are the cases that in the Netherlands have certainly created a lot of unease because of the need for interpretation by others of what constitutes the nature of the current suffering of patients. So one of the questions there is loss of capacity in and of itself, a form of unbearable suffering for people who have lost capacity, who previously expressed the desire that they no longer wanted to live if they would no longer be able to have meaningful interaction in their perception. Another issue that the report certainly highlighted was the so-called disability paradox, which is the dissonance between the predicted value of the quality of life of healthy people who are imagining what it will mean in the future to be in a certain situation. So this is often something that has been emphasized in the context of dementia, that people have a hard time appreciating that they still could have a pleasant interaction with the outside world when they are in a certain circumstances. So in the context of advance request for MAID, this was also raised as one important issue. I think I'll keep it more or less to those critical comments in order to enable us to have some discussion about the cases. But let me say maybe one more thing about the final conclusions of the Council of Canadian Academies report. A big emphasis was placed on issues of uncertainty that arise more generally in the context of advance requests for aid, so not only in the context of dementia. And I would say the focus of the report in the end was a lot on what are the ways in which we can diminish the uncertainty of decision-making in that context. Some people felt that you can actually do quite a lot and that it becomes a question of managing that uncertainty and finding ways to overcome that uncertainty by tools of supported decision-making, looking at particular defined criteria that were identified by people in an advance request for aid, such as I don't want to continue to live if I enter a nursing home. So a very specific solution to the question of uncertainty. Others felt that these technical means of solving uncertainty don't fully give us an understanding of the ethical dilemmas that people face in the context of medical assistance and dying on the basis of advance requests for aid. So what does it mean to make decisions, interpretations of a person suffering based purely on a prior expressed wish, so on personal autonomy of the person, rather than looking at what is the lived experience of the person right now. So I think there was a fundamental disagreement sometimes at the level of the panel about whether we can actually even overcome, whether it makes sense to just focus on technical means to overcome the uncertainty that is involved in the decision-making in that particular context. The report went into detail of the evidence of other jurisdictions, but we have to come to the realization also that there are very few jurisdictions that allow medical assistance in dying on the basis of advance request in the context of dementia. So the Netherlands is basically the only country that allows medical aid in dying of people who have a prior expressed wish when they are still interacting with others but don't no longer have full capacity. So the Netherlands only has also a limited number of cases, but the practice is increasing. So one of the significant developments in the Netherlands is that we started with nearly no cases of advance requests for aid, simply because of the fact that in the Netherlands there was a perception that you also still have to be able to interact to some level, with the patient about the nature of the suffering. Was the suffering really unbearable at the time when the euthanasia procedure has to be performed? And so for a very long time in the Netherlands there was an understanding that you can't perform euthanasia since you can't, if there is no meaningful interaction anymore, you cannot be sure that the person is suffering unbearably. Some flexibility has developed in that context, which you see reflected in some of the cases that we will be discussing. So I'll keep it at that. I think we should enter into the discussion of some of the cases, because some of the ethical dilemmas will come to the fore when we discuss these cases.
Thank you very much, Trudo. You know, my own reflection on that experience was people were coming at it from such different perspectives of training and culture and orientation. You had a very legal perspective that's driven a lot of this in Canada, of course, with the Supreme Court decision legislation. You had a medical perspective that's quite different, and you also have different cultural perspectives as well. And I'm going to go around now, and we may end up drawing on cases, and asking my colleagues on this panel if they can reflect on some of their principal learnings and conclusions in the going on 3 years since the Carter decision and their lived experience. And I'm going to start with a clinician, if I may.
Okay. So one of the things I find in doing these assessments is that people's ability to give competent consent may vary over the course of even a day, particularly patients who are in and out of delirium when they're very ill. And so one might see somebody at 10 in the morning and they'll be perfectly competent. and at 2 in the afternoon, they may not know their next of kin. And so one has to be very careful in making decisions about competency, both at the time of the assessment, but also at the time of the implementation. And so I would say that in some of the cases, I see that in one in particular, the determination of competence was made a couple of months before the implementation. And as a clinician, I would find that very unacceptable. In fact, many of my colleagues who do the implementations have said, I want it done within a few hours of me actually injecting the drug. And I've actually been asked to come to the site where the drug is being administered to determine competency at the time of the injection, because there's been some question. That's not common, but it does occur. So the whole issue of fluctuation of competency and how that might reflect on clinical practice. The other issue is the whole issue of the 10 days of reflection. And while one can understand that that was probably implemented to prevent rash, impulsive decisions, it does in fact mean that some people suffer intolerably over 10 days. There are the 2 exceptions, that they might lose competence within 10 days or they might die within 10 days. But there are certainly people who do not meet those 2 criteria, who are suffering terribly and who have to wait 10 days to get the injection after they have fully met the criteria. So those are 2 on the ground kind of effects.
We'll come back for more. Alison?
I'll just disclose that when I started doing this kind of research, I was sort of agnostic about MAID, and I felt like, well, this is a good idea. As a bioethicist, my training involved watching the Dax Coward case, and in case anybody's not familiar with that, it's a case of a young man who was horribly burned and underwent terrible debriding of his wounds, and it was all against his consent. He was deemed incompetent to be making decisions because he was so depressed at the time, but he went on to become a lawyer and has been advocating ever since that he should have been allowed to die. And the Sue Rodriguez case was carrying on when I was doing some of my education, so I was very aware of these cases. But since doing now close to probably 50 interviews with clinicians who are either directly involved with MAID or some kind of end-of-life care, it's struck me that it is far more complex than I could have ever imagined. And I have to say that I have, while I in principle am still supportive of the idea of MAID, I think that we have some really serious issues to work out, and a large number of those issues stem from the framing of MAID as a right, and because my research is focused on clinicians and their experiences and their understandings, particularly around suffering, one of the most interesting things that was unexpected about my findings has been the suffering that gets transferred to the clinicians themselves. Not just in the provision of MAID, but also in end-of-life care, which sort of highlights the social conditions in which people are working in this context and in which people are dying in Canada, and that there are lots of issues that a rights conversation tends to hide around the equity issues around access to palliative care, the multiplicity of ways of understanding suffering, that suffering, a dominant conceptualization of suffering seems to be that it's some kind of loss or disintegration of the self, but that there are other traditions and religions who have different perspectives on suffering, and that it can actually, if not positive experience, at least it can be meaningful, and that we have just adopted this dominant ideology that it's a loss of some sort, and that there really isn't a lot of room for discussion around alternative ways of looking at suffering, because we had focused so much on just the autonomy and capacity and rights issues related to this conversation. So I'd like to see some of those broader social, ethical, philosophical issues get some airplay in the public discourse around MAID.
going to jump out of sequence a little bit and just turn to Scott, because you were making comments about an interview you had with a physician about definitions of suffering, relations to pain, and how one would quantify suffering and what suffering means. I think it was phrased as an existential kind of suffering, for example, as distinct from pain or something like that. And I thought maybe this is a moment to put that notion on the table.
Can I put it in a slightly bigger context?
Oh, sure.
That cuts across our topic today. Because what I would like to try to bring together based on your question is the fact that we're talking about dementia and euthanasia, or maybe mental illness. And then we're at a law school seminar, right, with lawyers and doctors. So how do we put all those pieces together? And I think going back to your first question, what have I learned over the course of interacting with people with this issue is that from a legal, ethical, I'm a philosopher, so I love ideas, but I understand that ideas are tools. They're not masters. And as tools, we sometimes forget that they're very blunt instruments, and that, you know, when you start using them, they cover lots of things that we didn't mean to cover. So let me just illustrate what I mean, and I hope I can get back to this. And you gotta stop me because I just start talking and my kids think I'm just really long-winded, so I go over. But my point is that there's lots of apples and oranges in the actual world of clinical practice, decision-making, assessment. But from a legal, ethical point of view, we tend to use same terms to cover everything. And then how do we reconcile that? I'll give you an example. I think Donna really very well described the universal finding across jurisdictions about end-of-life MAID, which is that it really is motivated not by intractable pain and lots of physical problems, but rather people, it's a small minority of people who have real difficulty with what we would call existential crisis or suffering. This seeing what they're going through as senseless, purposeless, and so forth. Some people deal with that, some people deal with it differently. And that is the issue. Now, she also mentioned that they tend to be people, I think this is, I don't mean to insult everybody in this room or even me, it's just that they're people like us, okay? People who are highly educated, who have means, and who have really need for control, all right? Now, that's true for end-of-life MAID. However, we're talking about, let's say, mental illness MAID, okay? Mental illness MAID, well, who are the people with mental illness who want to die? Well, usually it's not because they're anxious about controlling the manner of their death. It's actually a situation where, due to certain personality factors, their mental illness, many social circumstances, they no longer want to continue to live, which is not how to die, but whether to continue living, right? And their socioeconomic conditions and so forth are very, very different. However, we have to analyze that case with the same law, same ethical concepts. Should we? Or should we take seriously the differences in the clinical reality and the lived experience of people and try to figure out, okay, this is really different. We need a new way of analyzing this situation. So I would say that there is a certain need to not just simply adopt ideas as masters, but as tools that are going to help organize how we live together. And you do that by looking to other areas of experience and knowledge that have to inform these policy decisions. So I don't know if I answered your question.
Well,
I was really long-winded, I apologize.
You weren't long-winded, you were sort of talking about your learning, but we were talking about your interview with a physician who, when he walked in the room and asked the patient, you know, what's the cause of your suffering? And the patient said, well, it's my pain.
Yes, I mean, you know, when you talk to experienced MAID assessors, doctors, Whereas, as you know, if you pick up a newspaper, why do you need to make laws? Because people with cancer are dying in pain, and they should be allowed to end it the way they want to. That is the paradigm, you might say. But in reality, that's not what it is. Because, in fact, it's so obvious to doctors who do these evaluations that that's not the case, that when they hear pain, red flag goes up, and they actually delve into what clinical measures we need to take to make this person feel better, right? And it's only after you do that, it's really the existential crisis that people are in that become the cause for continuing to request pain. I think that's what we were.
Yeah, Donna, you were
Well, I was going to
revving
say,
up.
I would qualify that because I think it isn't just only about control. I think control is very important, but I think pain is also very important. There's both physical pain and existential pain. And certainly I see a lot of people with both of those.
Yes. So I guess, you know, it's part of the terminology, because what I meant to say is that it is more the existential crisis and pain that we're talking about.
I think it's pain too. All the people I see are in palliative care, they're on big doses of morphine, and they're still in pain. Physical pain.
Well, we can look at the studies today, looking at that.
Marcia.
So many issues, I hardly know where to begin, but I think that one thing that I'm really interested in is understanding better the relationships between the assessors and people on assessment teams, various hospitals, all the stakeholders involved, and the patient or the person requesting made, and the eligibility criteria in many cases I see is extremely subjective in terms of how it's interpreted. And I find it fascinating to sit at the table with a number of people who are doing the assessments and who are facilitating the assessments, and to observe the diversity of opinions they have about what's going on. And the value projections that are occurring. Because even in the, been involved in some writing around what questions should we be asking to understand people's motivations. And why is it that I'm even making recommendations about particular questions? Well, they're pretty much based on my own particular values that are being projected as well. And the kinds of questions that I'm asking are really going to be leading in many ways. And there is so much variability in subjectivities. And in some ways that's good because you want a more person-centered approach. But on the other hand, if we don't have the right sort of balance, whatever that looks like, objectivity and subjectivity, what are we really doing? We want to be able to treat each person uniquely because of how unique each person is, and understand, for example, if you have somebody with autism who has a different way of making sense of making decisions, do we adopt their particular world, how they make decisions when we assess their capacity, for example. So I think that as well, we need to pay a lot of attention to the debriefing sessions so that after each area of assessment, from motivation to first assessment, second assessment, we have an opportunity to reflect on how the assessments have occurred and what kind of variability there is between various assessments and various assessors. And from a very much our own values and principles that are being projected.
What did you learn?
So I'm a lot, and yet it's led to way more questions, frankly, because I work in the field with patients who are seeking, and I see that side of it as Donna. We oversee all of the cases that come to the hospital. One of the things that I want to come back to, I want to raise the issue of what to do with fluctuating competence. And as a bit of an aside, this is not, as far as I know, embedded anywhere in formal policy or legislation, but the way that we are treating it in our practice is that we consider the 10-day reflection period to be something where that is meant for reflection. And if someone is in a state of delirium and they're fluctuating back and forth, we essentially reset the clock for the 10 days. Because otherwise you could get someone at one point in time on day 1 who has capacity and then has capacity on day 9, 10, and 11, but in between had lost it. Would you consider that adequate reflection? So that's just as an aside. But one of the things that I've seen in terms of the families we see, not just the patients, I will have to say that the vast majority of them are very appreciative of actually receiving aid. And they are in situations where the patient and their loved one has been suffering, and they actually find a peaceful path that they did not think they would have. There have been a few exceptions where what has happened is the MAID assessment process has kicked in an assessment to ensure there's adequate pain management, adequate palliative resources in the community offered, etc. And on a few occasions, people have actually changed their mind. Now, you can mark that as oh, that's something that's good, the patient has exercised their autonomy, which they have. But it should, from a quality perspective, clinically raise concern. Because what it points to is, were these people who would have gotten MAID because they lacked access to some form of care that would have offered relief, and instead they would have gotten MAID. So the issue of access and adequate relief of suffering is embedded with whether we think there should be ready or easier access to MAID, and certainly whether it gets to a point of the right for MAID. So the flag, I would say, is that if you don't have ready and easy access to care, and you make much ready and easier access or right for MAID, which costs a lot less than care, by the way, there are some potential risks there. And this then ties me into the points that both Scott and Donna were making. And I wonder if sometimes we are talking about different patient populations. In the jurisdictions that have, like North America, that have the requirement for either reasonably foreseeable or some time frame of that, you do get a certain demographic of people who actually are not disadvantaged. They tend to actually be high functioning, they tend to have that autonomy and control over their lives, and they now wish to also have agency over their deaths. When you look at the cases of mental illness, as Scott has, who've received it in the Benelux country, a different picture emerges. These are not people who are advantaged and privileged. They're actually the ones who tend to be impoverished and lonely. So a very different picture, potentially different patient populations, and that has led me to a real dilemma, because when I started looking at this, I would tend to frame things in this dichotomy of, medicine, we're supposed to do no harm. So just this dichotomy of do no harm, help me die, and can both be true. And I think they can in many situations. So that was the initial dichotomy. I now see it a little differently. It's more along the lines of, what if there is no Goldilocks solution? We are looking for a solution that will allow people that we think should get MAID to get MAID, and then not allow others who we think probably shouldn't get it. From my practice, I have, every psychiatrist will have patients they've seen who have gone through periods of terrible depression where they retain capacity, and you know with certainty that they would pass any competence test or requirements to seek MAID in a state of potential suicidality. And then many of them years later, they actually are feeling better and they are glad they didn't either act on it, and yet they know they could have received it depending on what the framework is. So how do we both allow people to get it who society thinks should, and protect ones who maybe we think shouldn't? So the issue becomes, if there's no Goldilocks solutions, which mistakes do we want to make?
I'm going to ask a few of you, maybe if you want to reflect on Sonu's question, which mistakes do we want to make? Anybody want to jump into the fray?
Well, maybe if I can, because we want
sure.
to start discussing the
we
cases,
will.
and so
Okay.
I'll say something about what I see as the kind of the key issues in these cases,
Okay.
and then we can get a discussion going and also involve people in the room. So very briefly, what I see as a kind of the things that I learned when I see a lot of these cases that have been translated for in this version as well, some of the accounts coming out from Belgium and Netherlands. With respect to the mental health cases, I would say the first that is always striking to me is, which is you can confirm if this is true, but particularly significant in psychiatry, the uncertainty of the diagnosis and the changing diagnosis over time with many of these mental health patients. The fact that we're dealing in these cases in Belgium and Netherlands with people who suffer from social isolation, often have personality disorders, often are difficult patients, which complicates matters, which complicates relations with patients. The fact that there are often very divergent opinions about the unbearableness of the suffering, and the fact that there is no hope of recovery. So disagreements among specialists involved, among the primary physician, the consultants, and so on. I would say also the involvement in the Netherlands, which my reaction would be we would see the same in the Canadian context, is the involvement of specialized end-of-life clinics who don't have a long-standing treatment relation with the patients who ask for euthanasia, because often the treating psychiatrists are reluctant to provide it. With respect to the...
do that? You kind of said the words end-of-life clinic really quickly. How many people here know what he's talking about? Okay, so I think you should explain what the end-of-life clinic is.
So these are specialized clinics that have developed over time in the Netherlands because of the fact that very often patients, particularly in the more controversial areas, like patients with dementia, like patients with mental health issues, who were not receiving euthanasia or were told by their primary care physician or the psychiatrist that they were not willing to provide it because they thought that the due care criteria of the legislation were not fulfilled. These clinics have developed over time as specialized clinics that are only focused on evaluating and providing access to euthanasia. So in principle, they're not there to treat the patient. They're there to basically provide access to euthanasia when they think that the due care criteria are being met. Me, from a regulatory perspective, from somebody who looks at issues around the regulation of the profession, I see there a potential for conflict of interest and concern, that there is this kind of specialization in terms of providing access to aid in more controversial areas. So the proportion of dementia and mental health patients that these end-of-life clinics serve is very high compared to the other doctors who provide euthanasia more generally. So I would say it's important to kind of look at that for why is that this develops. Particularly also because in the Netherlands, the philosophy behind euthanasia was always that it develops. It was always emphasized that there is some kind of safeguard as a result of a long-standing relation that most Dutch patients have with their physician. And the idea was that to actually provide euthanasia within the context of a long-standing treatment relation doctor-patient, where the doctor basically can empathically understand what's going on with the patient and see that this is not a flare of the moment, that there is a kind of a long-standing desire and a long-standing efforts to help the patient get better, have failed. They are being paid, so they do receive funding to do this. I wouldn't say that they do it, but who knows? So I would always say, when you raise this issue that people are being paid for providing euthanasia and that this may create conflict of interest, I think we sometimes naively have the reaction, oh, you should never expect that people will develop a practice which creates a kind of a pressure to do so. I would say in any area of medical practice, we have overdiagnosis, overtreatment. So yes, there are concerns about some level of specialization or a single focus on developing certain practice.
Sonu, you were going to...
Well, I just wanted to, when I hear things about the end of life, the issues that Trudeau is raising, yes, they have to be considered, and Scott, you know the numbers on this better than I do, but my understanding is that in that standalone end-of-life clinic model, so again, the model where the physician who knows the patient is not doing the assessment and is typically actually declined to kind of proceed because they feel due care hasn't been met. If there's a difference between how many are getting it in those clinics for medical illnesses versus psychiatric illnesses, again, that should also raise questions. And there's a huge difference that in terms of the numbers overall, I think less than 10% for medical illness in the country go through the end of life plan. And yet over recent years, the numbers for psychiatric conditions have not only been much higher, but increasing. So over 50% from a few years ago, and increasing in each of the 3 years since that there were data, to the point where now over 3/4 of all the psychiatric illnesses that are received, you may get it through the standalone clinics, and yet less than 10% for others. So again, in addition to any of the other things you would need to consider, that should raise some, at least caution about why that is.
Could I just add a little perspective to that? So the end-of-life clinic came into being in 2012. It was initially funded by the main euthanasia advocacy organization in the Netherlands. It's my understanding that now, because they provide services that are recognized, they don't have to be completely funded by that organization. And K.Sonu is exactly right. Of the cases that we study, I would say between 30 and 50% of the cases that involve psychiatric illness as the basis, or dementia, the doctors who are asked first, which is usually their primary care doctor or their own geriatrician or psychiatrist, refuse. So that would be about between 30, 40-ish, 50, that range. It's a minority, but still a large minority. The reason for it is a little bit mixed. It is due care not met in many cases. Sometimes, especially the dementia cases, the doctors don't want to do dementia cases because of this issue of not being able to fully have a reciprocal interaction. What this reflects, though, is even the first case of psychiatric made that tested the case and the Supreme Court in Netherlands recognized as okay was in 1994. People don't quite realize that this has been an accepted legally practice for 20-some years. However, it wasn't until about 2011 there began to be a slight steady increase in that country. So now it's up to about 80-some cases. So that would be in the US. If it were in the US, where it's a large country, it would be about 1,600 cases a year. In spite of that steady increase, what's happened is that there's polarization within the psychiatric and medical community about these practices. Some people think it's okay. So very few doctors account for the vast majority of psychiatric euthanasia cases in the Netherlands through these clinics. So that it's not a kind of a community kind of practice, really. And that's true in Belgium, too. There was a period in Belgium where probably majority of cases were done by a single, evaluated by a single psychiatrist. So there's, after 20-some years, when you survey Dutch psychiatrists, their willingness to conceive, the way they phrase the question is, can you conceive of yourself providing MAID to your psychiatric patient, to a psychiatrist? That number has gone down now to 37%. Now, this is in a country where among doctors, support for MAID in general is well over 80%. So for these cases, even after decades, it still remains controversial and it's the minority. So it's an interesting experiment they've run. The numbers are increasing mainly because this is my account of it. It's profession is polarizing. Some people are now more willing, but it's the small number. Small number are willing to do it, more willing to do it, so the absolute numbers are increasing, you see, even though fewer proportion of doctors are willing. So it's a kind of an interesting cultural development in that sense.
From the standpoint of learning from this, from assessing this as we go ahead, this learning process, you think about it, there are only a very small number of jurisdictions who are doing it. So we're really in the beginning days if you look at it from the standpoint of a broad population. I'm curious to know how you think one should collect the data, how one should do the oversight, and then I want to get into some of these cases and see how they might play into that. So I start with the clinicians first. Donna, what kind of information do we need to have, do you think, to advance the learning process, if you will?
I think there are many things we don't know. What I do hope is that we're collecting that evidence as we go along. I don't think the new federal reporting requirements are moving in that direction. They look more bureaucratic to me. I think there are a number of very interesting questions. You know, what motivates people? What access do they have to services? What kind of supports are in place? How much palliative care do they have access to? I think those are very valid questions. I think, too, it would be quite interesting to look longer term, perhaps at their relatives and what they feel about this a year down the road. Because I think that there might be some very interesting information that might come from that.
Alison, do you want to take a shot?
I think I'm going to pass at the moment. Yeah.
Simon?
The only thing I'd add to what Donna's saying, I agree that there's a dearth of information and we're still not collecting all of the things we would benefit from. But in addition to families and the effect longer term, the effect on MAID providers and also on others who were involved in the circle of healthcare who were not MAID providers over time, that's really not terribly well studied, and it's certainly not well studied for non-terminal or non-reasonably foreseeable natural death situations. So most of the study on impact on care providers is in the sorts of situations where we now do MAID in Canada, for example. But if we're talking about potential expansion to other circumstances, just the impact of that on somebody who has provided care to a patient for many years, and that patient now receives MAID, may have lived for another 20, 30, 40 years.
I like to see a better understanding of what we mean when we say vulnerable. Like, what is vulnerability? Because, if you think about people who are asking for MAID, it seems like there's sort of two camps. The ones that are pretty autonomous, educated, want control of many aspects of their life, as already been said, want to direct what their death looks like. And then it seems there's, not correctly conceptualize it, but the other camp, like those who are vulnerable, who maybe for social, political reasons, haven't had access to either services or other requirements that other population groups have access to. So are they being driven to request MAID really from a lack of major lacks occurring in their lives, as opposed to feeling that they're not coming at it from a point of view of vulnerability. But I think we really need to understand more what it means to be vulnerable and how it is that the law is apparently set up to balance or to be able to respect people's autonomy, but also to protect the vulnerability of the vulnerable people. And I'm not really sure what that means. And I think until we define better what we mean by that, I think it's going to be hard to start measuring that and looking at data.
Yeah.
I mean, I'm not sure if there's time for audience participation, but I think that was a good segue for me to make a comment.
Please.
I represent Mr. Foley in a case to restrict the law. Our position is that there are inadequate safeguards, and the legislation actually leads to unnecessary deaths and too much suffering because it's not restricted enough. And I think that there needs to be a way to make sure that we provide for people that are vulnerable as much as allowing for individuals who perhaps are very autonomously driven and are professionals who want to access made. So I think before we, before we're moving just in one direction, we have to consider all aspects. And I just as representing Mr. Foley, I'd encourage. I know he maintains his own website. I would encourage everyone to look at assistedlife.ca. So assistedlife.ca, and look at what happened to Mr. Foley. And he would be concerned at the movement of what allowed what has happened to Mr. Foley. And we have a case before the courts, and we hope that there's more restrictions of access to MAID, and that it shouldn't be extended to people with mental disability and mature minors, and for advanced directives, because right now we're not doing a good job at actually implementing the current law, because people are not being assisted with life and getting access to health care, and are making existential decisions of why they want MAID. And my position is there's carnage. There's carnage that's happening in Canada to people now, unfortunately. And I think as professionals, as doctors, physicians, politicians, I think it's important that we tighten up things, because we really don't know what's actually happening at the bedside. And if you look at what's happening to Mr. Foley and other Canadians, what is actually happening at the bedside, not necessarily looking at it from far away, that I think we need to tighten this up.
Yeah, and then I want to move
So
back.
I don't represent Mr. Foley, so I'm
That's
speaking
fine,
as an
that's fine,
academic.
sure.
I just want to draw a general point about what you said, because and this is a point I agree with, which is that I think K.Sonu mentioned the Carter decision, and the reasoning there was really interesting, because it said that people are being forced to forgo life. In other words, they weren't given what they deserve as true options to make choices, right? So I think that reasoning is a very important one, and it led to, I'm an American, so I can say this, it led your country to adopt a law that says in order to make sure everybody has true options, one of the things you have to do is have this made law. Okay, so that's your current situation. I think that reasoning, though, really generates so far very under-discussed obligation on the state, I think, which is, that means that when it comes to this life and death decision, since you use this principle to say that option has to be there, there is a strong pressure, I would think, to make sure that people who go through this process requested truly have true options. So making sure that the person who chooses it had palliative care and so forth. So I agree with Donna's idea to make sure that the key areas that you have to study, to me, the way I would frame your concern, vulnerability, and Donna's point, is to frame it around, is the state of healthcare and other social services support such that people who are asking for it, receiving, are exercising the genuine options that the Supreme Court said was the basis for your MAID law. So I think that would be the kind of how I would organize doing research, because it seems to me, and when it comes to mental illness, for example, where the waiting list in Ontario to see people to get psychotherapy in Ontario is quite long, as if you look at
And it's about to be completely changed.
For the better,
Yeah,
worse.
they're going to stop, apparently, they're going to stop funding psychotherapy.
So I'll just say one comment about this, and then, so it was pretty apparent in terms of the people's desire to die with psychiatric illnesses. I know we all see ads for Prozac and stuff, and we think, drugs are going to solve the problems. It's really about relationships, therapeutic relationships, that will have greater impact. And I worry that if that doesn't exist as a true option for people, it's say, so the kind of research I would encourage to do would be to make sure that the program lives up to its promise. And the way you do that is to make sure all the data about whether or not you can fairly evaluate that is in place. Sorry.
So it's interesting to say in this debate, because I think we want to kind of go back to the area of mental health, particularly, and dementia. It's true that we have in Ontario, as in many other provinces, very bad mental health services. But then the argument is often thrown out, and I throw that here on the table, that if you prevent access to medical aid and dying because of the lack of access to good mental health services, you're punishing people doubly. You don't give them the solution of therapy, and you don't give them medical aid and dying. So this is not my argument, this is an argument that is often put forward. It has been in your working group of the Council of Canadian Academies also been put forward, because that for me a concern when that argument is being put forward. You basically undermine the kind of the broader pressure on the system to improve, first of all, before you move further to any more devastating consequences, that you improve the healthcare system first, before you even start thinking about more radical solutions.
So just as an analogy from many years ago, if I may, I'm an oncologist, and this debate actually took place in microcosm around the treatment of pediatric leukemias about 40 years ago, when the notion was that all of these children were going to die within roughly 6 months. There was nothing you could do, and the physicians who were pushing to advance the care came under very substantial criticism because, of course, in some of the initial treatments, they didn't work so well. And they were defended by their institutions against the social pressures of the day. And lo and behold, that pediatric leukemia is largely a curable disease now. So there's a kind of analogy from years gone by toward this. I do want to return to the cases and just make one other final comment. The Council of Canadian Academies expert report, the mandate was that we should not be making recommendations. That was very clear. There is an implicit recommendation that has come out of that report, and that is, darn it, collect data. And each of the panels, while you couldn't make a recommendation, said we really need to learn more. And so these conversations, not to speak of the patient things, are part of it. Trudo, let's get to some cases. Oh, some of them. Oh, I'm sorry, I didn't see your hand.
So I've been a psychiatric nurse for 45 years. I work primarily with people with schizophrenia. They're impoverished. They live together in boarding homes. I work in Parkdale. We don't fund care the way that would enhance the quality of life for these people. Whether it's diet, whether it's access to medical care for the conditions that our treatments cause, with metabolic syndrome, diabetes, heart disease. There are lots of problems, and mental health care is underfunded, so that's a problem. I just wanted to add, when you were thinking of what else to study, our patients live in communities. They date each other. They live in boarding homes for years together. Thank goodness it's hypothetical if we talk about MAID for mental illness alone. But I think what's going to happen in that population of people who live together, who are a community, once somebody has a medically induced death, they know each other. They're going to feel vulnerable. It's their doctor that maybe participated in the assessment. Anyway, just something else.
Yes, sir.
I just wanted to add this. Before they brought in a law that allows this, I actually did a DLMA for 10 years in negotiations because I got to know doctors very well. This is before they brought in a law. There was a lot of discussion going on at the time. There were doctors there who wouldn't tell everybody this, but who would tell you if they were honest, euthanasia was taking place, and it has been taking place in hospitals for years. Not in the cases of mental illness, not in the cases of dementia, but in the cases where the people are under extreme pain and they're in their life. They'd be given an extra dose of morphine that the doctor would know would kill them, but it would be that merciful, and it would be relief of pain, and that happened. And I think that probably still happens, and it's now been codified under this particular thing. And I think that system, that kind of a situation is different from the two others that are under discussion, mental health and dementia. I think those are three almost totally different kinds of situations, and I think we should think about it that way. I want to tell a little story. I was in a nursing home, and I was preparing a lady who was in charge of the nursing home for a case, and I kept on hearing this voice. I told my friends here this, and I heard nurse, and I heard nurse, and I heard nurse, and this would get louder and louder and more panicky, and then it would stop, and then time would go by, and 10 or 15 minutes later it would start up again. And I was there for maybe 3 or 4 hours, and this happened every 15 minutes for 3 or 4 hours. And finally I said, what's going on? She said, oh, it's a terrible case. This gentleman has dementia, serious dementia, and he doesn't remember, and he's gone blind, and so he's panicking, and then he's told what the problem is, but he forgets it in 15 minutes. And that struck me, as you said, about the best example of how I can think of while you're still alive. That's a dementia problem. So when you get to be my age, you see, somebody tells me that I've got Alzheimer's, and I remember that circumstance. I want to be able to tell someone, look, I don't ever want to be into that circumstance, and I want to be able to give advance notice of that. And I've had 2 of my best friends die from Alzheimer's in the last 10 years. So I see that as something that needs to be addressed, and that is somebody should be able to avoid going through that. And right now, there's no way to do that. I see the mental health problem, as you very carefully put it, Bill. You're absolutely right. People who I have patients or clients, not my patients, but clients of mine who are mentally ill, and that I act on. I'm their, I have the power of attorney, and it's a constant battle back and forth because they're suicidal. That's because they're sick. So that's like a separate kind of circumstance. And I think lumping them together and saying we're going to come up with some kind of plan to deal with these 3 different kinds of situations the same way is going to be, you're not going to be able to do that. You can think of them as distinct kinds of problems and deal with them in a different way.
So maybe if I may comment on that, because we can get into the case more specifically, but I think these advanced requests for dementia cases are interesting because they deal with an illness that is devastating. Nobody wants to suffer from Alzheimer's. I've had a father-in-law die from Alzheimer's. My mother is currently suffering from Alzheimer's. So yes, these are devastating diseases. Nobody wants to, or people want to avoid. That doesn't mean that there may be a solution. You see, I think we often underestimate the challenges of implementing solutions to things we don't want to do. So in the dementia context, what do we see developing in the Netherlands? We all want to avoid Alzheimer's, but we generally don't want to die too early. So we specify in the future that we don't want to recognize our family members. Again, this is a sympathetic claim, so I can see that we find this currently devastating. But there is a difference between us feeling that and then obliging the state, doctors, the establishment, to provide a solution, which basically means that you sit down people who no longer fully understand what's happening to them, who, not always, I don't romanticize Alzheimer's, but who have fluctuating moments of pleasure, illness, sadness, satisfaction, dissatisfaction with the care they receive. So people who are there, who interact with you, who speak, who sometimes refer to things they may still remember, and these people don't fully understand anymore what's happening. In the Netherlands, you have these cases where people are being sat down, either surreptitiously medicated before so that they fall asleep, so that they can be euthanized afterwards, or basically you sit them down while they don't know why they're being sat down and what is happening when their life is being ended. Is that a solution that is acceptable? I don't know. So maybe this.
All I
When
can
we,
say
when we do when we do that, actually, when we do that, you have to kind of ask yourself the question. We do that on the basis of a prior expressed autonomous wish of what we don't want to happen to us in the future. There are many people who are in that situation who never expect any desire. When we say we have to end your life in those circumstances, it means that we accept with you that this is a life not worth living, that this is unbearable suffering. We say that then about a lot of people who are currently among us.
all I can say is that guy, I asked how long it's been going on, and they said weeks. And I know that I would not ever want to be in that. That is the best definition of hell I can think of. And someone should be able to avoid being put in that position. And the guy's being kept alive in a nursing home while he's suffering that. And so one could argue, we had this argument 4 years ago, we had Professor Dickens set up a thing here at U of T in 1980, I believe it was, where we discussed whether or not there should be euthanasia at all. And the same kinds of arguments came out then. But, you know, when you've got someone who's going through that, somebody should be able to, they should not be forced to go through that. And they're being kept alive in a nursing home. If nobody was looking after them, they'd die. So the argument that I have is you are medically interfering in the quote natural process by keeping them alive, in this case in a nursing home. They'd be dead if they were out anywhere else. And yet you are causing them to have what I think would be about the worst kind of suffering one can imagine. So I think that's something you have to put into the equation when you're talking about these issues. And sometimes, you know, most of the time, these people who are in that kind of a circumstance are being kept alive because of some kind of medical intervention. And when you intervene, I said this 40 years ago, when medical science intervenes in the life process, they have some responsibility to make sure that that doesn't create more suffering than they're actually preventing. And I don't think that's been taken into enough of an account.
But we currently actually can, in sort of circumstance, for example, you can stop certain forms of treatment. It's not a problem, you see.
Well, they're being taken care of. They're in a medical establishment. They're being given drugs to help them, and you know. Anyway, I said enough.
Yeah, Sonu and then Alison.
It's okay, actually, I'll defer. I think other people had some comments.
Alison.
I wanted to pick up on what you were saying at the back there about the issue around trust. I think if we zoom out from this micro level of provider-patient interaction and we look at some of the broader ethical and social issues that these practices raise, I think I hadn't really thought about it. I've thought a lot about public trust in the context of public health and its interactions with the public, but I think certainly, I think that's a great point that we need to look at, if we have providers doing this with, however we want to define vulnerable populations, where there are maybe deep trust issues to begin with. That may be a consideration that we haven't really thought about too deeply, in that there's enough difficulty already building a therapeutic alliance sometimes with patients who feel extra vulnerable for various reasons, and that implications of being afraid that those protections in law are not enough, and the idiosyncratic approaches that at least the research that I've been involved with has revealed about how people are assessing suffering in different contexts. I think that was a really interesting point. Yeah.
Sorry.
Thinking of the principle of double effect or unintended consequences, heroic medicine. Many years ago, it used to be before antibiotics, what my father would say when he practiced medicine, that pneumonia was the old man's friend. And then suddenly, there was a time when you could modify. And the issue is it positive or is it negative, notwithstanding one's intentionality? And it's something to consider in terms of technique. And I use that in terms of the artificial sense, which is that, well, to say it's value neutral is pushing it, but there's no such thing as say absolute value neutrality. But how far do you go? Where do you draw the line? And therein is in terms of judgment, sagacity, and you can construe ethics, you can bring in other elements. But the point is, in terms of technology, how far do you push it as opposed to what the corpus or what the body can do or not do on its own. And then you introduce capacity, which is another element altogether different qualitatively, but quantitatively, perhaps yes or perhaps no. But the point I want to leave you with is technology or heroic medicine. Where do you draw the line in terms of what is good practice?
Well, I think there is, as a clinician, I think there's a distinction between saying, I don't want any more care. In other words, I don't want more care, withdrawal of treatment, and the active intervention that assisted dying or whatever you want to call it amounts to. So, and I suppose as the chair I shouldn't, or the moderator, I shouldn't be making a comment. In my informal conversations, I'm fascinated by how frequently there is public confusion about that distinction. And I've had very intelligent people who've thought about this for a fair bit of time say to me, I think, we should make MAID more accessible because otherwise they're going to force me to have treatment. There's a substantial public misconception about that out there, but your point is an important one, and people need to recall that they can say no.
So actually that raises in it, because there are two kind of buckets there that are very kind of opposing sides of the same thing. To some extent you're talking about omission versus commission, but you're talking about it in terms of heroic measures to keep someone alive. The other side we can look at is how much of a difference is whatever intervention you are making, whether it's through omission or commission, how much of a difference in course or path is that making? And that's part of what we're talking about here in terms of what would the impact be on expanding criteria and increasing access. I mean, you talked about the issue of whether it's access or a right. Because as soon as you say that something is a right, then it no longer is, well, by omission we are allowing someone to die who might die anyway. But then it becomes, well, no, maybe now by commission. And legally, ethically, are they different or not? That's for you guys to debate. But we're now saying that there's a right that by commission, we are going to foreshorten someone's life because they have a right to ask for it in whatever set of circumstances. And that could be changing their life course for 10, 20, 30, 40, 50 years. So I think those are very separate things.
Scott, I saw a hand in the back corner here.
Yeah, hi. I just wanted to air something, I guess, that was troubling me a little bit about some of the conversations. I work at a hospital downtown, just sort of across the street, and I know that it seems to be, there's this practice of MAID there where it's become, I don't know, a little more acceptable to characterize a certain patient population as accessing MAID. So there seem to be some comfort now as being established with, oh, the person who's really in control, that's the kind of person that we feel comfortable accessing MAID. And I guess I'm wondering about the cultural biases and assumptions that we bring to this topic. And I do think that there's a cultural assumption and bias and comfortness with these kinds of patients that are able to access it now. Like, for example, we don't worry about them being called aggrandized, or they don't suffer from a psychiatric diagnosis that I know of where it's an overinflated ego or sense of self. But, I mean, perhaps some of them do, or it's a lifelong condition. And I worry that that's clouding our judgment of seeing other cases in mental illness as not fitting the typology of the person who should be able to access MAID. And I do think that there's certainly relevant differences in terms of mental illness around, I think the case with a depressed patient who's suicidal wanting access to MAID is a different kind of case than, say, the anorexic patient who's been struggling with anorexia for 20 years and is just can't do it anymore and is suffering. Like, these are different cases and need to be assessed, but I just worry that there are some cultural biases and assumptions that are coming in and unduly influencing who we see as candidates for MAID. And I also worry about professional interest too. So much goes into the therapeutic relationship in psychiatry. And I worry that there was an oncology example. Sometimes I worry in oncology, people, they're never told what the true prognosis is, or it's treat, 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 treat. How many of those patients who would have known truthfully from their oncologist that, you know, look, you only have 4 months left to live, you know, you should think about what you really want to do. How many of those patients with truthful information about their prognosis would actually access MAID? And I guess I'm worrying about the therapeutic relationship and the honesty and the concern of professionals feeling like they failed their patients and not being able to, especially in the psychiatric context, really hearing the patient's need for this kind of an option.
Anybody want to respond? Yeah, please. Oh, I'm sorry.
So I'll actually comment on that briefly, and I think those are excellent points actually, because the way these dynamics play out is multifaceted. In terms of the therapeutic alliance, it can play out in that way where you feel I can't give up on my patient, etc. So that's one potential risk of us bringing our own view into it. But that also is a two-edged sword, because when, you know, I experience frustration and sense of hopelessness not being able to help somebody who hasn't gotten better for a length of time, all psychiatrists, all doctors know. The flip side of the risk of wanting to continue conveying hope, the flip side is having a sense of, you know, I actually can make a difference by, you know, I'm no longer powerless. I actually can help the patient, and by helping them, I will help them access MAID or end their life. And again, that may be okay in the circumstance of the patient, but psychologically the way that plays out internally for the treating professional is I've now re-empowered myself by providing this. So my point is that there are risks in both directions, that in a sense of frustration and helplessness, which no physician likes to have, there is a risk that we may also undertake an option that empowers us, but maybe it's not always best for the patient. It's complex.
So let's take a look at one case. Oh, sorry.
I just had a very quick question, and that is, some of the comments that I've been hearing seem to suggest that we're talking about a population. It seems to me doesn't fit exactly with what the Rodriguez and Carter cases and all that framed, which led to the legislation, which is that there are people who make decisions they no longer want to live, they don't have the physical capacity to carry that out. So in some of the psychiatric or psychological cases that we're talking about, are we talking about people who have physical capacity, or are we always talking about people who lack physical capacity?
To do what, suicide?
Yes.
It's not part of the, so in the jurisdictions where it's allowed, physical capacity is not brought into consideration one way or the other. So you could be allowed, you could have physical capacity to act on suicidal thoughts. And still
apply request made.
They're physically able to.
That was the point I was making at the beginning, that agency to act physically is rarely lost with psychiatric illnesses.
So if I understand you correctly, let me just make sure I understand your question correctly. You're saying that the cases that drove this in Canada were based on the physical incapacity to act, and yet the discussion here is people where that limitation is not an issue.
I'm asking you a question, is that the case? Like, because I'm wondering, because if that is where it's going, it seems to be opening that basket up tremendously.
I'm not sure if I understand the question. Are you saying that if you're understanding that currently only people who can't physically end their lives receive MAID?
No, I'm wondering how we got from the point where those cases sparked the issue to the point where we seem to be discussing access to medical assistance in dying in a much broader framework.
Yeah. So my question is, even putting aside the two topics that we're talking about today, you're already practicing MAID for people who can physically end their own lives currently. So are you asking a question about that practice
I'm
as
saying
well?
rather concerns about the fact that it seems to be getting to be a pretty large basket of situations where this is being facilitated.
Trudo.
So I think the point goes to something quite important, which is indeed the Carter case and Rodriguez case before, dealt with specific cases that many people would say are sympathetic cases to legalize medically dying euthanasia. And so, yes, we've kind of constructed from that a right in specific circumstances to have access to MAID, which is now the pressure is to expand that to situations that certainly don't fit that kind of scenario of a person who has declining capabilities and who is close to the end of life. It's an interesting phenomenon. And so I think it goes to the question, should MAID be seen as an exceptional procedure that eases the transition between life and death, people who are in the process of dying or close to, or should it be seen as some kind of medical therapy that goes beyond these specific situations close to the end of life and deals with existential suffering, all kinds of reasons why people may want to die. And the additional question to that is then, is that a neutral thing to offer? Will it have no impact on what's currently happening in the context of mental health care, in the context of how we care for people with this dementia, how we care with people with cognitive disabilities? So I think this is a key question. Why is it that we, from a small set of circumstances, where we see that many of us have sympathy for the idea that MAID can provide an easier transition to people who prefer to have some kind of controlled transition between life and death, that we're now seeing that as a kind of a normalized medical procedure. I think in the Council of Canadian Academies that was often the tension, certainly in our panel, and I presume also in the panel on mental health, that some see this as a kind of a medical therapy for a wide variety of purposes, but we see that more as a kind of a transition in exceptional circumstances. The interesting thing is that there's no country that says it should simply be available. It should be available for cases of unbearable suffering. But what does that mean, unbearable suffering? When we go beyond the end of life context, how do we contain a practice? How do we, from a regulatory perspective, I would then say, how do you provide any form of regulation and oversight if you allow individual physicians to interpret, yes, this is unbearable suffering, no, this isn't? I mean, how can you ever criticize a physician or a healthcare provider from providing it to individual patients? So from the perspective of protecting patients, I find that worrisome.
I would like to answer your rhetorical question. How do you refine doctors responsible? The answer is you don't. In countries in which the most number of these cases have been performed, I would say if I add up the Belgian cases with the Dutch cases up to 2017, from 2002 that was legalized, you would have probably between 60 and 70,000 cases. At one moment, Belgium, about 2016 or 17, had 13,000 cases of euthanasia. Only one case was reviewed by the panel as not having met due care criteria. In other words, Dutch doctors, or the Belgian doctors, were virtually perfect in 12,999 cases. In Netherlands, there were 50,000 cases about, and about 0.18% were found to be due care not met. Remember, due care means several things. It could be by not using the right meds, right doses, and so forth. Those accounted for the majority of the due care not met, 2/3. 1/3 of the 0.18% had to do with the eligibility criteria. Even those, generally, they were found to violate based on procedural grounds. Not this person didn't qualify, but rather this doctor, when evaluating this criterion, didn't seem to be careful enough. So when you add all that up, a retrospective review system, which is the system that every jurisdiction has, or to some varying degree, very opaque in Belgium, quite transparent compared to other countries in the Netherlands. The idea that doctors are at risk, legal risk, and so forth, It's only recently that there are actual court cases after the laws were passed that are in courts now. In Belgium, there's 2 court cases. Both of them were judged by the review committee says okay, but the families were persistent. They thought it wasn't done properly, it just was wrong. So they pursued, and there was one criminal case and one case that went to the European Court of Human Rights. So anyway, I just wanted to, I knew it was a rhetorical question, but I think that the review system issue is a very interesting one, because if you set up a retrospective review system, treating it as kind of best judgment of doctors, you basically, I mean, it's not a, kind of a, you might say, a stringent oversight. Yeah.
But if we think of Canada, there were several patients who went to emergency rooms in Quebec with a do not resuscitate handwritten note after an overdose, and the physicians did not give the antidote because, and they weren't prosecuted, their ethics official on their medical board, we call it CPSO in Ontario, just said, well, there was confusion about the law. So I don't know if this is gradual application of a new law, but if people are not prosecuted for not following the requirements of the law, there's no, that's Canada. It's not Belgium, it's not the Netherlands.
I've reluctantly looked at my watch and it's approaching 4 o'clock, and I can see we've solved all the issues. I wonder if from any of others in the room there's some questions or some thoughts that you may want to offer. It's an extraordinarily rich and engaging and challenging topic that we've opened up. But I'm serious. Are there any passing thoughts that anyone would like to add? I'd certainly welcome them, as would my colleagues. Well, on that note, I'm going to thank you all for coming, and to our panelists. I can tell you that when we get together to talk about this, it's one nuance after another. It's more and more complicated, and I think it's a beautiful example of what happens when you start with a simple idea and then try to translate it into the real world. So I thank you all and for your questions, for your contributions, and for your presence.
Reception now. We're going to say a few words of thanks. We have a digital piece.